Hello, I'm Dr. Jim Epstein, and this is Best of the Day from the 2012 Chemotherapy Foundation Symposium in New York City. This is the 30th edition of this meeting, which goes back to 1972 when it was originated by Dr. Ezra Greenspan, who unfortunately passed away in 2004, and now this annual meeting is held in his memory and in his honor. It's been a very interesting meeting. There's been a lot of very rapid, quick-fire presentations of data, but a lot of very interesting information. And on this final day, we're sitting down with Dr. Mark Christ from Memorial Sloan Kettering Cancer Center to talk about lung cancer and some of the interesting material that was presented today. So, Mark, welcome to Best of the Day. Thanks so much for coming.
Love talking about lung cancer.
Well, lung cancer did not get as much time today as I thought it certainly deserved. I mean, you guys were crammed into about an hour or so, and it was awfully fast. And I think that's sort of a shame because it's a really exciting field, and there's a tremendous amount of data that's coming out now, and much of it is stimulated by people like you who are really looking at the molecular genetics of non-small cell lung cancer. So let's start off with some of the material that you presented today, talking about adenocarcinoma and the molecular profiling and breaking that, what used to be a large entity, down into very separate, oncologically driven malignancies.
Well, doctors that took care of persons with lung cancer knew all along that it wasn't one illness. You had 100 people, and it was very, very unusual that any two of them had the same course, let alone the 100 of them. And we struggled to find a reason for that. Why did some people get better with chemotherapy? Why did some people, no matter what you do, have a horrible course? Why did some people live for a decade? You just didn't know. And what we've been able to do in the last almost decade now is to take the lung cancer tissues and analyze them for specific driver mutations, changes in the DNA that are fundamental to the growth of that cancer, the development, the maintenance of that cancer. These drivers are very potent. You know, they're DNA based. It's generally one driver per tumor, and they are the proximate cause of the cancer in those patients. And because they're so fundamental, if you knock them out and knock out their effectiveness, that cancer cell generally gets knocked out as well. At the same time, scientists, pharmaceutical industry has come up with drugs that are very potent and specific antagonists for the effects of those drivers. So when you have the right driver and you have the right drug, the cancer shrinks dramatically. And we've seen that over and over again with lung cancer.
So it seems like every month or two you see an article about a new oncogenic driver identified in adenocarcinoma. I mean, the last one was the KIF5B RET mutation that I think Pasiani has published on. How many are there now that are identified, and how frequent are they?
Well, there's probably about 10 drivers that everybody agrees upon. There's experimental criteria for what's a driver, and there's probably 10 of those. And again, the interesting thing about those drivers is when you negate their effect, generally those cancer cells die. You mentioned about the RET. I mean, that's the latest version in this story. I first learned about it last Thanksgiving. There was a publication from a group in the Far East about RET. And it's just amazing. Here in basically less than a year, we have been able to test patients' tumors, give them drugs that are currently available that block the RET kinase and make their cancer shrink. It's just an extraordinary story. And the story should be played out in lung cancer is even more extraordinary because it was one of those illnesses that was always at the end of the session and had a little bit of time devoted to it because people really, frankly, didn't have much hope about it.
Right. And so, I mean, there's KRAS and EGFR are the most common, and we've heard about the EML4 ALK fusion protein. And many of these just seem to be drivers in 1, 2, or 3% of people, but when you consider how many non-small cell lung cancers that's still a pretty significant number of patients in the U.S.
Exactly. In the U.S. alone, each year there's about 135,000 just adenocarcinoma cases.
Right, that's
so
a lot.
1% of adenocarcinoma is over 1,300 people. So even if you say, oh, it happens in 5% of cases, that is almost between 5 and 10,000
Right.
people. Putting it in context, there are roughly 20,000 cases of ovarian cancer in the United States every year, 20,000 cases of esophagus cancer, 20,000 brain tumors. So having 15% of lung cancer is in that same range. It's
Right.
absolutely huge, and it's a huge impact. And the impact of the drugs in those populations is pretty amazing. Going from all the difficulties that chemotherapy brings on, and particularly the biggest difficulty that only a minority of the patients have a really substantial benefit, to suddenly go to a treatment that is, taken on the way to work literally, and you can expect a response. It's just an extraordinary story for tens of thousands of people.
So it's very important that if you can identify a driver for which there is a target and a drug directed at that target, so you know what the best first-line therapy for that patient is. But there's a lot of malignancies out there right now in lung cancer for which a druggable target has not been identified. What should docs in the community look for? Obviously, they need to look for EGFR, and now with crizotinib available, they need to look for EML for ALK. But what about some of the other less common ones, BRAF and HER2 and PIK3CA and all the others?
So if we go to our current version of the NCCN guidelines, step one is still to get an accurate histologic diagnosis, and that has become even more critical as well. So I mean, that's the first step. You have to get enough tissue so your pathologist, who are very expert in making these diagnoses, can tell you, do you have adenocarcinoma, do you have squamous cell carcinoma, or do you have small cell carcinoma? That's step one. For the adenocarcinomas, where it's clearest now, the guidelines specifically state to test for EGFR and ALK in everybody. And if you don't have enough tissue, and it can be safely done and practically done to even do a rebiopsy. That situation is changing now because our colleagues in the pulmonary community, thoracic surgery, interventional radiology know that we need tissue for these mutational tests, and they're obtaining sufficient sizes of samples whenever lung cancer is suspected. The way that testing, though, is being conducted in our pathology departments and laboratories, though, is so-called multiplex testing. More and more, every test for every driver is done on the same specimen at the same time. So I like to think of it like as a CBC. I don't think it's possible to order a white blood cell count and not get the platelet count and not get the hemoglobin. It may be, but I'm not sure of how to do it.
Yeah, no longer.
Yeah, but we deal with that, and we understand that the way the test is constructed, it makes more sense to do it that way. And even if you didn't need the hemoglobin, you didn't need the platelet count, you get it anyway, and you deal with it. You use it or you don't. It's the same thing with these tests. As the technology has become more precise, more automated, it's become faster, it's become cheaper, and now it's pretty standard that on one specimen, using a modern, what's so-called next-gen platform, you can get anywhere from 50 to 250 genes, all at the same time, all in the same specimen. Within those 250 genes that you get all these known drivers. Which ones are the most important? Well, probably EGFR and ALK are the most important because we have drugs sitting in our pharmacy that we're able to act upon those, and we have the most experience and understanding. What we've also seen, though, in the last year or two in particular, is that the other drivers that we find on these multiple tests are actionable as well. I showed an example today of a patient that I had discovered a BRAF V600E mutation, the exact same mutation found in malignant melanoma. I wrote a prescription for vemurafenib for this person. She took it to the specialty pharmacy, it was filled, and lo and behold, 4 weeks later, her cancer shrunk.
That's amazing.
No. So it was no clinical trial, it was no special situation that Sloan Kettering had, frankly. It was just a patient, working with her provider and the specialty pharmacy and got the drug. This is fundamentally different than many other kinds of treatments where there's some evidence something may help. This is biologically driven, and it makes so much sense, and that's why it's happening. So we can do that with BRAF. We can do that with HER2. There are mutations in HER2 in cancers of the lung, and if you give agents targeting HER2, like trastuzumab or like some of the next generation tyrosine kinase inhibitors like dacomitinib or afatinib, you can block HER2 as well.
So it's not just amplification or overexpression?
No, it's not. Actually, probably mutations in lung cancers are more common than amplification. Mm-hmm. Amplification only occurs in maybe 2 or 3%. But mutations are there which are not found in breast cancer, but they are readily found in these multiplex panels. The other mutations that are very actionable are the rearrangements in the ROS gene, rearrangements in the RET gene, RET gene. There are some other ones available too, but RET could be treated with a whole bunch of agents. Available ones would be like vendetinib, sunitinib, sorafenib. ROS can be treated with crizotinib.
Right.
I didn't mention MET. If you have amplification in MET, it too could be treated with crizotinib. So we have these drugs available, and both in clinical trials and in the pharmacy now. Right. And they can be had with the right degree of persistence and clarity to the insurance providers.
Right, and there's a lot of MET TKIs and MET antibodies that are under investigation now.
There are. I didn't get into the investigational piece of it, but every one of those 10 drivers has a drug available that is in testing right now, every one of the 10. And many of them have multiples. And you mentioned MET. My guess is there's a dozen drugs that have MET as a target.
So one of the first that was available, I think we really had drugs before we definitely knew what the target was.
That's true.
Was EGFR.
Yes.
I mean, we had gefitinib and erlotinib, and we were treating people for overexpression when it was really the mutation that was the target. And the responses in the EGFR mutant, especially the deletion 19 and the exon 21 mutations, are phenomenal. But they don't last forever.
They don't last forever, and that is part of this whole process. And it's not just in lung cancers. We've seen the same things happen in gastrointestinal stromal tumors, chronic myelogenous leukemia with imatinib. We've seen it happen with BRAF, vemurafenib in BRAF positive melanoma. And yes, but even that is a better situation than we have now. And I'll use chronic myelogenous leukemia as an example, because when you have this what so-called acquired resistance, you know what the mechanism is. They find specific drivers of the acquired resistance. There's a second site mutation. That's probably the most common mechanism of second site mutations in GIST tumors and in chronic myelogenous leukemia and in lung cancer as well. CML is a good example. I believe there are 3 drugs now approved since imatinib for those persons that have imatinib-resistant cancer, 3 drugs that could be tried. And now there's this whole discussion that maybe giving one of those drugs first would do an even better job, looking at strategies to give drugs together to kind of prevent or slow acquired resistance, just like we do with antibiotics. All those things open up. But the critical thing is, if you understand the biology, it's so much clearer, both for the care of an individual person and also for research. And that's the beautiful thing about these drivers, because you know what the problem is, even in this acquired resistance setting. And it's taken some time to come up with drugs. We don't have a drug right now for adenocarcinoma of the lung that develops EGFR mutant lung cancer that develops acquired resistance. But we have some, we know how to manage these patients, and we have a lot of drugs in testing.
I mean, erlotinib and gefitinib are reversible inhibitors, but there are a whole flock of irreversible inhibitors that, at least in models, look like they would be effective against the T790M mutation, the most common cause of resistance. But in actuality, can they do that, or are they just more potent binders to the site? Drugs like afatinib and some of the other pan-HER irreversible inhibitors?
Well, in various experimental systems, drugs like afatinib or dacomitinib seem to be better. They seem to be more potent inhibitors of the mutant kinase. They also, and the wild type kinase, they also seem to have activity in some models of acquired resistance, but not all. And so far in the clinical testing, at least when you look at the first line treatment, the results are quite comparable, about a 70% or so response rate and about a 15 to 20 month time to progression. So at least at first blush, they all seem to do the same, despite differences in toxicity, differences in binding. It may be that when they're ultimately compared head-to-head, and really they haven't been so far, that one may emerge as a more successful strategy. You know, I think right now the management of acquired resistance is in a tremendous state of flux. And it's kind of interesting because these oncogene-driven cancers violate everything that we learned in oncology school, as I call it. You know, for example, that even when your cancer grows, it's still important to continue the drug. That's probably the most fundamental change. If somebody told me I should do that, I would think that they had lost their mind. But that's exactly what we should do. So, you know, we've been learning with these oncogene-driven cancers. Actually, it's been very helpful because we've had the GIST tumors. Almost all the lessons we've learned for EGFR were there in GIST, and I've learned a tremendous amount by following that literature in those cases. So for acquired resistance now, as we look for new drugs, we have to take care of the people today. And the first thing that we do now, which again makes no sense compared to what you may have read, is that if you have a cancer and it grows slowly, the patient's asymptomatic, we do not change the therapy. As it turns out, if you were to dissect out that tumor, you would find that the vast majority of the cells in that tumor are still sensitive to the TKI. And what we've seen, if you happen to stop the TKI in those patients, the cancer grows more quickly, so-called flare phenomenon. Explodes, yeah. The resistant cells, unfortunately, go on their merry way, but the sensitive cells still remain sensitive. Tony Mock has a great slide, which I show to a lot of people, about this phenomena. And one of, I'll call it the tyranny of resist as well. So think about it. You have a 5-centimeter tumor that at the start of the therapy. It shrunk to 1 centimeter. It grows to 1.2 centimeters. It is now resist progression. Yeah. So what do you do? The case that Tony shows is a person that had that 1.2 centimeter tumor, and he watched them for the next 3 years, and it became 1.3 and 1.4 and 1.6 over a 3-year period, and nothing else happened to that patient. It would have been tolerating the medicine, cancer controlled. It would have been foolhardy to stop the medicine in that patient. So that's exactly what I was taught to do, and I would tell everybody they should have done. The other thing that's happened sometimes is that we have these cases where the cancer grows in only one spot. Sometimes it's a spot in the lung. Sometimes it might be a spot in the bone or the brain. And in those cases, what more and more people have been doing is you stop the erlotinib temporarily, you treat that one spot with radiation, with a surgery, cryoablation, whatever is the best thing, and then you start back on the erlotinib. And we've collected our series for the EGFR patients, and I think the average time that they're back on erlotinib, once they restart it, is like 1.5 years. And that doesn't make any sense either. They've already progressed, they have growing cancer. You treat the one spot of cancer and then continue the medicine, but it's borne out. And that same strategy has been used by the Colorado team in patients with ALK-positive lung cancer. And it's pretty much a standard of care now when you have an ALK-positive patient with that one site of disease. You treat the one site, then put them back on crizotinib. For those patients that have growth in many different sites, I think the treatment there is to add something to the erlotinib. And generally what's added is some chemotherapy. But we would add it to erlotinib.
Okay. So then would you intercalate the erlotinib with the chemotherapy, or just do it continuously?
I would just do it continuously. One thing we do have is, for various reasons, an extraordinary literature that it's safe to give erlotinib or gefitinib with chemotherapy. There's absolutely no synergistic and, frankly, no long-term toxicity. It's absolutely safe. We also have data now in EGFR mutant patients, trial that was done by Dr. Miller and Dr. Yane from Dana-Farber, that giving chemo with erlotinib in mutant patients imparts no increase in toxicity. There's kind of cool experimental evidence that you get an even better result in those patients that have acquired resistance by giving erlotinib and chemotherapy than giving either one alone. So that's been our bias to do that.
So how do you decide between adding just like one agent like pemetrexed as opposed to adding cisplatin and pemetrexed?
Yeah. I don't have a good way of advising people as what to do in that situation. I think one thing that is clear is that these patients are more sensitive to chemotherapy. I think even in the IPASS trial, when you look at the mutant patients, those that got chemotherapy had a 50% response rate. Pretty amazing, actually. So I think they have a greater sensitivity to chemotherapy. The other issue for those patients is at the time of acquired resistance, they've in essence had a life almost not disrupted by cancer. And it becomes very hard to give a tough agent like cisplatin. And also knowing that even agents that may be less toxic than cisplatin could be given safely and could lead to good results in those patients. So my own tendency would be not to give cisplatin because of all the attendant difficulties that go with it. We would tend to give pemetrexed, and we would tend to give bevacizumab as well.
Right. And so when do you decide then that erlotinib is no longer the agent of choice and you want to try to switch to a different tyrosine kinase inhibitor or a different approach to the molecular driver?
Well, the truth is people always have some sensitivity to erlotinib. So unless you have, until it's close to the end of life. So unless you have a drug that pretty much can give you good control of those erlotinib sensitive cells, I continue on the erlotinib and would continue chemotherapy and chemotherapy. If your question was when do you decide to intervene, it's pretty much symptoms. And you have more than one site that cannot be adequately handled by a local treatment.
So if you've got progression and you decide to do a biopsy and you find that they have developed the T790M mutation, do you just continue the erlotinib, or does it depend upon the penetrance of that new secondary mutation? Or when do you try like one of the irreversible inhibitors, or try to add another agent like cetuximab to the combination?
So it's operationally, again, this is an evolving. I think early on, before we understood the course of many of these patients, the minute the cancer grew, we would switch them to a clinical trial. Unfortunately, virtually every clinical trial that's been done in this situation has been negative, with very rare exception. So what we've done now is we tend to follow that same paradigm, treat only when symptomatic, when you have multiple sites, and then we would recommend a clinical trial. So far, there isn't any one strategy that has been proven successful for the majority of patients. In fact, most drugs that have been tested have not been helpful in that situation. What we do is we ensure blockade of EGFR, the sensitive cells, so we either continue erlotinib and add in other drugs. So for example, we have a trial now adding in AUY922, an HSP90 inhibitor, with erlotinib. And there's preclinical data to support that as well.
Right.
The other trial that we have been part of is to add cetuximab to afatinib. We don't have these next generation or second generation TKIs available now, so they're only available on clinical trial. So we can't make that switch right now, but I think that will be an option pretty shortly because afatinib has completed a phase 3 trial, and the hope is that it will get approval shortly.
So let's move on and talk about KRAS. Probably KRAS mutations are one of the most common mutations, but it's not an easily druggable target. If you have a patient and you've done mutational testing and they're EGFR wild type and there's an obvious driver, but they are KRAS mutant positive, is this patient just a candidate for chemotherapy? Or are there agents in investigational studies that are worth looking at to address that target?
No. So KRAS, again, we're in New York, so I'll use the term, it's the big matzo ball out there. Those of you that were Seinfeld fans know what I'm talking about. It's the most common mutation, and it's the one where we have had the most difficulty coming up with a good strategy. As amazing as it is, knowing that this mutation is present for almost 20 years, there have been almost no trials in KRAS populations of patients. Actually, I think Greg Riley, testing the drug Reversible, was probably the first one that specifically got these patients. Even though there are a quarter of our patients with adenocarcinoma, no one even tried to corral them in.
I saw some information about that drug a couple years ago, but I have not heard anything about it recently.
Yeah, well, it unfortunately didn't meet its endpoints in that trial. But one endpoint it did meet, though, it showed that you could do these kind of trials. The other thing that it showed is, there's this idea that if you have a KRAS mutation, that it's an immediately deadly mutation. That's not true. Like every other kind of lung cancer, there's a range of outcomes, even with specific KRAS mutations. And we're trying to dissect that out now. It may be that specific mutations in part sensitivity, in part longevity, different KRAS mutations. But people are just doing that now. There has been some data that mTOR inhibitors, or drugs that mine that PI3K mTOR pathway or parallel pathway would be helpful there. And Greg Riley showed some data with an mTOR inhibitor at this meeting with retiforolimus. We had previously shown that giving everolimus in a specific KRAS mutation, G12F, led to partial responses. So people have been looking at that. People also have been developing combined treatment strategies using inhibitors of the RAS, RAF, MEK pathway, along with inhibitors of the PI3K, mTOR pathway, putting them together. And that's been a very effective strategy in the lab, and several individuals are trying to move that forward in the clinic.
So looking at MEK inhibitors?
But not just a MEK inhibitor, but a MEK inhibitor with a PI3 kinase inhibitor. That was the data from Dr. Engelman that said that could be an effective strategy here, and a number of people are trying to pursue that. We have some data that bortezomib could be helpful, particularly in G12D or the KRAS mutations found in never smokers. Very early in the bortezomib trials in lung cancer, it was discovered that some patients had responses. It turned out they had RAS mutations and they were G12D. So we have a few inroads, but there isn't a one strategy now. I think the short answer is you give chemo, and you would avoid those other drugs, and that's helpful too. I think the chance of erlotinib being helpful in somebody with a RAS mutation is very, very tiny, and you're going to do much better with chemo.
So what about squamous cell? I know at ASCO, Govindan gave a very eloquent presentation of all the genome testing in squamous cell that's being done. Are you finding that there are potentially druggable targets in squamous cell carcinoma?
Well, yeah, I need to find out how to get this information out, but at the same ASCO meeting, my colleague Paul Pack has taken that one step further. I mean, we've known about the presence of these mutations. So what Paul did was to develop a multiplex system for squamous cancer. And what we have found is that just like in adenocarcinomas, we can find some sort of a driver in 2/3 of the cases. It's a different group of drivers, though.
Right.
It's FGFR1, it's PI3 kinase, it's PTEN, and it's another mutation called DDR2. For each of those, there are, well, DDR2, it could be targeted by dasatinib, an available drug, dasatinib used to treat chronic myelogenous leukemia. But the others, we only have investigational drugs. So there's a whole host of drugs that target PI3 kinase. In addition, what we found, and Paul Pack reported on the next-gen sequencing, is in addition to PTEN loss, we found mutations in PTEN. And it's very likely that they too impart sensitivity to drugs that are active on that pathway. And there's a huge number of them in trial now.
Right, because PTEN loss is pretty common in a number of malignancies.
It is,
but the mutations...
mutations less so, but you only find these things when you test them. And this again points to the necessity to do multiplex testing and the ability of technology to do that. We used an Illumina next-gen platform, and we were able to find some sort of actionable driver, actionable through clinical trials, not through drug therapy, in 2/3 of the patients. And that's pretty much what they saw in the TCGA that Govindan reported on too. The same group of drivers was found.
So do the PTEN mutations lead to constitutive activation of PI3 kinase?
In the laboratory, they can, but whether we're going to have that same link with drivers that we have with like a BRAF, we don't know that yet. Very few people have been tested. One deficiency of the testing of the PI3 kinase agents so far is most of the phase 1 and some of the phase 2 trials even have not been done in patients that have some dependency on the PI3K pathway, either mutation or PTEN loss. So I'd be careful saying these drugs aren't as good. The other thing that we've seen too, though, is that in the rare situations where we have more than one driver, and it's only about 5%, the most common other thing we see is a PI3K. So it may, and the fact that there's two of them could be interpreted saying that you don't really need two drivers. If you have a really good driver, you don't need a second one. Maybe the PI3K is not as potent. Maybe it's a kind of a co-carcinogen that needs to
supporting role.
Exactly, plays a supporting role. So, but these trials are in their infancy, and but one thing I would urge people to do is treat people with targets with targeted drugs. And there's virtually no data, and it makes no sense to me that you'd give a targeted agent to somebody without the target.
Without the target, right.
But that's common. I mean, if you just pick up the Journal of Clinical Oncology for a targeted therapy, new targeted therapy tested, only a tiny proportion of the people have the target.
Yeah, I've never understood why they do these broad trials in unselected populations.
Part of it's learning. I said already that we're learning things we never thought were true. There was a very potent paper at ASCO in 2011 by Dr. Simbaradou from MD Anderson. What they did at MD Anderson actually as part of their phase 1 program is they genotyped everybody, and then they gave them various agents. What they found was, and again, this is common sense, that when you gave a targeted agent to those patients whose tumors had that target, more cancers shrunk, more had, there was a longer progression-free survival and longer survival. And it was mainly for PI3K targeted drugs. So but that's revolutionary. If you go to somebody now and say, well, it's a phase 1 drug, say, oh, no, phase 1, any disease, any stage, but that's what we were taught in oncology school.
Right.
But it's not true. Right. It doesn't make any sense, actually.
Yeah. Throw it up at the wall and see what sticks.
Well, it was the right thing at the time.
Yeah.
We didn't have the technology we have now. We didn't have the understanding we have now. We didn't have the drugs that really went after those targets in a very potent and specific way. But now we do, and you can't go back.
No, oncology has become much more interesting in the last few years.
And much better. Yeah. I mean, it's all you need is to treat one person with a TKI, and you see the difference you make in their lives. it's gotten to the point it's almost anticlimactic. It's a lot of our patients now, they've been told they have lung cancer. They do a bunch of tests. They find it's metastatic. They get information from various places saying you have metastatic lung cancer. Your chances are very slim. And you got to do something right away. They come to see one of us. We do a test. We say, you have an EGFR mutation. Here's a bottle of pills. Please come back in 3 months. And the person is sitting there saying, what?
I might not be here in 3 months.
Right. Exactly, I might not be here in 3 months. And that's what's happened.
Yeah.
Sadly, it's not every patient. And sadly, 2 years from now, that cancer will grow despite those pills. But again, you're 2 years into the game, and there's so many more
Science
options.
will advance in those 2 years.
And we have options at that point. This is like a whole. At the very worst, it extends everything out 2 years and gives close to a normal life, which is fantastic.
Absolutely. Well, Mark, thank you so much. This has been very interesting. I think a great discussion of the evolution and the explosion of new knowledge and new data in non-small cell lung cancer. So thanks so much for being with us.
Thank you.
All right, and thanks to all of you for watching this segment of Best of the Day from the 2012 Chemotherapy Foundation Symposium. If you'll check on our website, you'll find all of the discussions from this year's meeting. So thanks again.